It's
Sorry, I forgot to start that earlier.
It's you know, it's a collaborative. We're going to learn from each other. We're going to throw around a lot of ideas. This worked really well. This totally tanked, and here's why, and here's what we'll do differently. So at any point today and anytime we're ever together, if you have questions, just jump in, just unmute and call out your question. You're welcome to use the chat box. I will monitor that box when I'm not talking, and I won't be talking for most of this, but I know Lori will be looking in that box too. So jump in, call out questions, don't be shy. I think that's probably good enough for an intro. I did want to go around the virtual room. So you can go to the next slide, Lori. And have you all introduce yourself? If there's a representative from your practice, I think we'll just start at the top. It's nice to see this map that traditionally we're very centered in Ohio and a lot of times right around Columbus, Ohio. And I love Columbus, Ohio, and welcome to all of you from Columbus, Ohio. But I love to see that we're getting some participation from other areas of Ohio, and then really cool to see participation from other states as well. Call out, because I can't not call out that Boone, North Carolina and Augusta, Georgia are both pediatricians who I went to residency with. They were in my residency class, Scott St. Clair and Jennifer Drake. So thrilled to have you guys both here.
Glad to be here.
And that's the first time I've seen Scott, probably since residency. But fortunately, and Scott, you're Cali today, apparently.
Yeah, Cali's my office manager, so.
I do get to see Jennifer from time to time, even all the way from Augusta, Georgia. So let's just start at the top. I moved all my people over to the top, so now I can't see the top, but I want to say, will somebody read out the top? And if we have a representative.
Sure, and I'm not sure we do today, but Metro Health Medical Center Pediatrics in Cleveland. I don't think we have anyone on from today.
All right.
Can you read the next, or do you want me to do that?
OSU Outpatient Care in Lewis Center. I'm going to take that as a no. OSU Internal Medicine and Pediatrics in Hilliard.
I will go ahead and just jump in. So I'm actually from the next one up, which is OSU Internal Medicine and Pediatrics in Grandview.
Good work. Thank you for jumping
so
in.
I think we're kind of, you know, not everyone's available for all the meetings. So we all work together really closely, these three OSU practices. And so, you know, I think, you know, we all keep in touch pretty well. So I guess I wasn't sure exactly, like, as far as intros, how much to kind of say, but I'll just give you a brief overview. You know, we're all located in Columbus, Ohio, and so our outpatient center in Lewis Center does have internal medicine and pediatrics, as well as regular internal medicine, and I think there's some family medicine out there as well. But I think the med peds folks are the only ones working on this project. So yeah, we're all excited to, you know, move the needle on this. And was there any other specifics you wanted to kind of hear about them?
No, I think you did an awesome job of being the first to go. So yeah, very good. Thank you. So Center for Colorectal and Pelvic Reconstruction.
I'll start out. I'm Cheryl Baxter. I'm one of the nurse practitioners with what we call CCPR, because colorectal and pelvic reconstruction is certainly a mouthful. We have a project, a QI project, very involved in giving HPV vaccines in our specialty clinic. And the next person is probably going to talk is Dr. McCracken, and I work with her directly. And there's 2 other nurse practitioners that are on for us too. They can introduce themselves, but thank you.
Hi, I'm Kate McCracken. I'm one of the gynecologists at NCH. And I'm serving in 2 capacities for 2 groups, both the CCPR group and then our pediatric and adolescent gynecology practice, which I'll let our clinical nurse lead, Natalie Alexander, also introduce herself. From a CCPR standpoint, we're really interested in this because we do complex pelvic reconstruction. And so doing routine cervical cancer screening as the patient ages is obviously more difficult to physically get to the cervix to do a standard cervical screening, which is Pap test. So we're trying to increase our HPV vaccination rates in this population to sort of reduce the risk of dysplasia in the future. And then in general, so that's for CCPR. And then for PAG, pediatric and adolescent gyne, we're obviously huge champions of the HPV vaccine, and it's something we do every day, all day in our clinics. And I'll hand off to Nat. I think she's on also. Thanks for inviting us.
Hi, everyone. I'm also here with Megan. She's one of our surgery schedulers. She's part of our kind of QI team here. But obviously, Dr. McCracken explained we are pediatric gynecology, so this is kind of what we do every day. We also had a QI project going to try to increase the rates. We noticed a big discrepancy in where kiddos would come to us and they wouldn't know if they had the Gardasil vaccine or HPV. They would say like, oh, maybe I got it at my pediatrician, or I got 1, or I got 2. So we kind of started a process of trying to get those records. So we're also very passionate about this and happy to be here.
I think several of you were on a call that I was just on. My first time attending the Contraceptive Access Collaborative. So I'm familiar with your names. I see Meg Kane. I was nodding. I was thinking, I think you spoke a lot during that. So nice to see your faces, and thank you for joining us. Hilliard Pediatrics.
They are not on today.
Okay. Is that Rob Snyder?
Dr. Lucen?
Oh, okay. School Health Services, Sarah Bodie.
Hi, everybody. Sarah Bodie. I'm a pediatrician at Nationwide Children's Hospital, the medical director for our school health services. And actually, our QI and research efforts are led by our nurse practitioner, Meg Kane, who's on. So I'll let her sort of introduce the clinic and the hopes for this particular project.
Thanks, Dr. Bodie. I'm Meg. I'm the clinical quality coordinator for school health services. We have, it says here 12 locations. We actually have 14 school-based health clinics in both Columbus City and Reynoldsburg City schools here in Central Ohio. A lot of our efforts, so we provide primary care in the school-based setting, and a lot of our efforts are around reproductive health care and inclusive of kind of addressing disparity, especially as it pertains to vaccination efforts. So this addresses a lot of our areas of interest, and we're really excited to be included. So thank you very much.
Thank you. Blue Ridge Pediatrics.
Yes, so Scott St. Clair, I'm a primary care pediatrician down here in the northwest corner of North Carolina. So great to see some of my residency colleagues. So this is fun to recognize that getting to join in with that. We cover about 3 counties in Northwest North Carolina and have a main office with 2 satellites, and realized as we were getting sort of pulling some of this data together that we have a huge variability amongst providers in terms of, you know, how well we're doing, I think, promoting this. And so I'm excited to say all of our docs, all of our extenders are going to participate. And I've got here with us today my vaccine coordinator, Sarah Townsend, and then Callie is our office manager. So anyway, we're excited to be part of this.
We're excited to have you. And Augusta Pediatric Associates.
Hey, I'm Jennifer Drake. I'm also a Cincinnati alum with those 2. We live in Augusta. We have 9 pediatricians here, general pediatrics as well. And we actually kind of came across this more from hearing Katie talk about the quality improvement project for our MOC stuff. And then as we're kind of thinking about it, it seems like we do have a lot of challenges here. There's a lot of local just resistance to acceptance of HPV vaccines. So we're interested in seeing how we can change that some, but even just by the way we speak and word and that. So I'm looking forward to it. And just FYI, the Masters is here next week. So we are getting revved up here. So glad to be here.
Well, thank you, everyone. This is just an awesome collaborative, awesome group. I love that we have so much representation from kind of different areas, not just geographically, but areas of specialty and practice, and really excited to have you all. Thank you all for joining us. And I'm looking forward to spending some time with you. I'm going to turn it over to Dave Karras. Dave, you're on mute. Dave is my co-director, medical director for this project. Oh, screen sharing. I think we're good.
Well, good afternoon, everyone. Thanks for joining. Thanks, Kate. My name is Dave Karras, and I am a general pediatrician. We're going to talk about human papillomavirus. Imagine that. And we're going to talk about how to address some of the vaccine hesitancy that we're seeing. So as I said, my name is Dave Karras. I'm a general pediatrician. I get to work in quality improvement and as a clinical informaticist and school health. I get to do lots of fun stuff. And really been actively fighting HPV since 2016. In 2018, did a case report with Merck on some of the work that we had been doing in Akron. We did a kind of network-wide quality project back in 2018, and I also serve on the medical advisory board for the Crawford Crew, which is a Columbus-based nonprofit that works on eliminating HPV disease. So this is definitely something that we care about. I do have a quick disclosure. I have done work with Merck, who manufactures the Gardasil vaccine. I'm not going to talk about anything that is off-label. And by the end of this talk, hopefully everyone will be able to describe the burden of HPV disease, explain how the HPV vaccine works, and hopefully be able to discuss with families all the reasons for vaccine hesitancy. So first of all, what is HPV? Well, it's another virus. We're used to telling families that it is just a virus, and this is it's not that different from any of the other ones. This is a DNA virus. There are about over 180 different types, and it only affects humans. So we are the only known reservoir for this one. And almost everyone gets HPV at some point in their lives, and it is in fact the most common STI. So if you've ever had sex with a human, it is very likely that you have been exposed to this little virus here. So what is the problem with HPV? Well, it likes to cause lots of different diseases. So we are all familiar with the warts that HPV causes. We've got some of our regular common warts over here, not pretty. Plantar warts, certainly tough to treat. The skin on the feet is just so thick. It's tough to get down to where the wart is. And then you've got these anogenital warts. I don't even know what body part this is anymore, but certainly they can be disfiguring. But warts are not the big problem. Cancer is. And so we all know that HPV can cause cancer. So cervical cancer has traditionally been the one that we're most vocal about because there are so many women who are affected, probably over 11,000 cases in the United States each year. But even more concerning is this big number of cervical precancers. So almost 200,000 women are going to be diagnosed with cervical precancer any given year, and almost all of these are caused by HPV. But there are other illnesses caused by HPV as well. Lots of oropharyngeal cancers, anal, vulvar, penis, and vaginal cancers. And HPV vaccination could probably prevent over 90% of those. So it's one that we are so excited about. And when we look at the burden of disease, we see that it really is so high. This is just looking at cases per day. So vaginal cancer is about 2 per day, vulvar 7 per day. Anal cancers, about 16 people a day. Cervical cancers, 27 women every day being diagnosed with cervical cancer. And that sounds horrible, but even more men are being diagnosed with oropharyngeal cancer every day. And so there are just so many reasons for both men and women to get this vaccine. And here's what's happening. We've got this nice, normal, happy-looking cervix over here. But you get these little HPV viruses that come in and they like to infect these epithelial cells and take it over and start making more and more virus. Unfortunately, the DNA from the HPV can get incorporated into the cell's own DNA, and it can start triggering the cells to reproduce themselves as well. So pretty soon you go from this nice normal cervix to these abnormal cells that kind of start growing out of control. And you can see the cervix already has some abnormalities here. And this is when we're seeing these cervical intraepithelial neoplasias. And these are the sources of all those abnormal pap smears that women get. I'm sure everyone knows someone who's had an abnormal pap smear. And this is really what we're looking at, trying to catch these before they progress to truly invasive cancers. And these are very common, and the vaccine is so effective that the number needed to treat, to prevent one case of any of these high-grade CINs is only 39. If you vaccinated 39 women, you've already prevented at least one case of precancer. So great job. But again, 1 out of just over 400 American women are going to die of cervical cancer, and there are more than 6,000 HPV cancer deaths in the US annually. Worldwide, almost 300,000 cancer deaths, and we can see that the rate of that oropharyngeal cancer is actually now higher than the rates of cervical cancer in women. So all that to say is that there is so much that we can do to help prevent very serious disease in our patients and families. So what can we do? Well, first, we can try abstinence. We can do like the Ricardos did and have separate beds. Very, very effective at preventing HIV. It's just not as fun, unfortunately. So we can try some other things. Condoms, not great. Unfortunately, HPV is not as much of a body fluid transmission, but it can be just skin contact. So unless all your skin is covered with one of these handy full body condoms, then unfortunately you're still at risk for HPV. So my recommendation is vaccination. It's actually very, very effective and very, very safe, and it works. So everyone should get vaccinated. So we need an HPV cancer vaccine. Let's make some. It's actually really easy. You take a snippet of viral DNA and you put it in some baker's or brewer's yeast. So here you've got some Saccharomyces cerevisiae, saccharine, sugar. See how that sounds similar? Myces, fungus, cerevisiae of beer. Like cerveza. So this is the sugar fungus of beer. What a great name. So we can put this into a plasmid. We can tell this yeast to start making these little L1 proteins. They like to self-assemble into these little shapes. And so pretty soon you've got these little viral-like particles. It's made of these viral proteins, but there's no DNA in here. It is not going to make anybody sick. Crack open the yeast, purify everything, inject it to somebody's muscle, and pretty soon your body's going to start making antibodies against the proteins in this shell. So super, super cool. And so it is indicated for people who are 9 through 45 years of age, both for men and women, indicated to prevent anal or pharyngeal and other head and neck cancers caused by HPV. Anal precancers, dysplastic lesions, genital warts, and obviously in women protects against cervical, vulvar, and vaginal cancers as well. So does it work? Yeah, it really, really does. This is one of the most effective vaccines that we have, and it's so, so exciting. So we know that in the first 9 years after its introduction, we saw rates of HPV-16 HPV infections decrease by 83%, 67% fewer anal genital warts, 51% fewer cervical lesions in women 15 to 19. So again, we know that this vaccine is already making a tremendous impact on the burden of HPV disease. We're looking at close to 100% effective at preventing vulvar cancers, 100% effective at vaginal cancers, around 98% for cervical cancers, very effective against genital warts and anal cancers. So again, so many great reasons for all of your patients to get vaccinated. So how do we dose it? Well, for kids 9 to 14, it's a 2-dose schedule. If we can get that first dose in before kids turn 15, they only need 2 doses. Spaced by about 6 months. You can do it as early as 5 months later. If the series is interrupted, you do not need to repeat the dose. There's no maximum interval. And studies are showing that for kids who have 2 doses before 15, it is even more effective than 3 doses in the older kids. So for older kids, if you're starting after the 15th birthday, those people should get 3 doses, then one at 1 to 2 months, and then 1 at 6 months. And again, if it's interrupted, it does not need to be repeated. Additionally, some kids with immune compromise should also receive 3 doses. Unfortunately, like any vaccine, there are risks and side effects. It kind of hurts, and you might be sore the next day. Some people get a little fever or rash, and we know that some adolescents are at increased risk of fainting after vaccines. So definitely encourage watching them for at least 15 minutes afterwards. But you all know that. The question is, how do we get families to actually accept the vaccine? And that's the challenge. So for those of you who got to watch Ted Lasso on Apple TV, you may have heard this quote. It's not actually from Ted Lasso, it's from Walt Whitman, but it says, "Be curious, not judgmental." And I think that if we enter those vaccine hesitant visits with this mindset, we are going to be tremendously more successful at convincing families of the importance of vaccinating their children. Vaccines are not new, and vaccine hesitancy is not new. So this photo is a kid with smallpox. It is horrible. It was not the great pox, which was syphilis, another STI, but this was bad. Fever, vomiting, mouth ulcers, horrible rash, about 30% fatality. Been around since ancient Egypt, and probably killed over 300 million people in the last century. People back in ancient China knew about smallpox. They knew that airborne transmission tended to be much more severe and that skin infections tended to be milder. So they were actually inoculating people way back in the 10th century. They would take powdered scabs or pus and put it in the people's nose or a small cut. And they found that this would then prevent them from getting severe smallpox disease later. And this was great. While 30% of people died with natural smallpox, maybe only 1 in 10 would die if you did it this way. So it was better. But we could do more. So back in the late 1700s in Great Britain, many people had identified that milkmaids tended not to get smallpox. And then if they got cowpox, which is a virus that was similar that cows had, it seemed to induce immunity to smallpox. And so numerous physicians were testing to see if they could create some kind of vaccine using this cowpox virus. So what they would do is they would scrape the pus from the milkmaid sores, because they were milking and getting cowpox, inject it into the patient's arm, then expose the kid to smallpox and see if it worked. Again, you're not going to get this through the IRB today, but Jenner did it, and he published in 1798. And this was tremendous. This was our first ever successful vaccination campaign. So again, this started in 1798. How long did it take for anti-vaccine movements to arise? Well, it didn't take long. Here's a drawing of people's concern about the cowpox vaccine. And you can see that it was causing literal cows to grow out of people. And when was that published? That was published in 1802 by the Anti-Vaccine Society. So within 4 years of Jenner publishing this, there was already a large anti-vaccine movement. So vaccine hesitancy is not new. Obviously, the modern anti-vaccine movement kind of was triggered by Andrew Wakefield's publication in Lancet back in '98 that MMR was responsible for causing autism. It's not, by the way. There was 12 patients. There were no controls. There were serious scientific misrepresentation and ethical violations. Wakefield was actually getting paid by lawyers suing vaccine manufacturers. And many of these patients had symptoms prior to vaccination. That study has been retracted. He lost his license. MMR does not cause autism, but there are lots of myths about vaccines. Families do worry that they'll cause autism. Families are concerned about adjuvants or preservatives in vaccines, things like mercury, aluminum, formaldehyde. They're worried about getting too many vaccines at once. Some families may feel that natural immunity is better. They are afraid it can cause infertility or promiscuity. And now with COVID vaccine, things like induced magnetism and something about 5G, I can't say that I understand it all. But we've all seen the media. We know all the things that families have expressed concerns about, and we've seen these ourselves. And part of the challenges are social media and the fact that things that are sensational and things that are exciting and things that are controversial and things that match your worldview are things that are all likely to get more clicks. And that's all that matters nowadays. And so you can do an article like this that says, Wisconsin girl dies as a result of receiving Gardasil HPV vaccine. At age 12, did this girl die from Gardasil vaccine? No, she died from diphenhydramine intoxication. It did happen after she got her shot, but it certainly was not the cause of it. And that's the problem, that many of these stories get published even before there's been an autopsy or confirmation of why that patient actually died. In Great Britain, this girl died within hours of getting her HPV vaccine. Horrible, horrible. Was it because of the vaccine? No, it was because of the giant tumor in her chest. It's still horrible, but it's not the fault of the vaccine. And with Gardasil vaccine, there have been just so many challenges in the media, so much misinformation. And a lot of it does have to do with things like the passive reporting systems that we have into place. So they can look and say, oh, there have been 8,000 adverse reports in 10 years. And maybe that's only 10% of the real tally. So suddenly you're saying, oh, that means there's 80,000 women out there that have had serious side effects. But it's not really true, because many of these are reported prior to autopsy. Again, we know that these sensationalized stories get more clicks. And many people in the media feel the need to present both sides equally. But the fact is that it's a false equivalency, because only one side actually has evidence. And unfortunately, we've seen that during COVID-19, the rates of hesitancy have only skyrocketed. There's so much increased polarization, decreased pluralism, and people are really, really into their heightened group identity. And we know that these search algorithms and social media and traditional media really have worked to polarize people and sensationalize things to increase revenue. And the more that people identify with their groups, the more they accept their group's beliefs and values. And so if you're in a group that is naturally hesitant about vaccines, it is so easy just to believe that without actually doing the research and looking at the evidence. And we know that the anti-vaccination movement really spans political parties. On the far left, there's distrust of big pharma and a desire to be all natural. And we know that on the far right, there's distrust of the government, suspicious of the scientific establishment, and cherishing of those personal freedoms and not wanting to have any mandates. So while we know that ideology does have a strong effect on trust in government experts, The data also show that political worldview does not seem to influence how much people trust their primary healthcare provider. So the great news is that families trust us. And we're the ones that really can make a difference when it comes to vaccine hesitancy. Families come to us because they trust us. They care, they expect us to care for their kids and their kids' health and to do the things that are in the best interest of their kids and their families. And so we really are in a unique place when it comes to talking about vaccines. So I think when it comes to HPV vaccine specifically, most of us have already heard the benefit of having a presumptive delivery strategy, meaning that we should go into every visit expecting that families want vaccine. If you come into that visit with hesitancy yourself, then yeah, the family is going to have a hard time trusting you about it. And I used to do it myself. I used to go in and say, you're due for your tetanus vaccine, your meningitis vaccine, and it's time to start talking about HPV, or have we discussed HPV vaccine? And again, you're already separating it, you're making it sound like something different, and really it's not. It is part of the same immunization schedule as DTaP and meningitis, so we should present it the same way. Today, your kid's due for tetanus booster, HPV cancer, and their meningitis vaccine. What if they say no? Well, that's our chance to have the conversation. If you can then respond with genuine curiosity and empathy and actually wanting to understand why the family feels that way instead of going in there on the attack and making them feel defensive, then we have the chance to actually have that conversation. Think about it. Why are families refusing vaccines? It's because they really believe that that is what is in the best interest of their child. No one wants their kid to get cervical cancer. They believe that the risk is low, or the vaccine is dangerous, or that it's just not right for them. But we really do have the same goal. We both want is what's best for that child or for that patient. But again, an argument or an attack is only going to make people more defensive. And for most people, the hesitancy is not due to lack of knowledge. It's due to cultural beliefs, perceived risk, and it's rare for evidence to overcome anyone's belief. And so we really need to identify those barriers by asking, what are your concerns about the vaccine? Because the fact is, vaccine hesitancy and vaccine refusal really are a tremendous and heterogeneous spectrum. There are people that are just going to refuse everything, and it does not matter what you say, they're never going to do it. And I think most of us will quickly identify those families, and sometimes we just don't need to waste our breath. Obviously, there are families that accept everything, and those families are easy. We love them all. They'll accept whatever we recommend. But there really is this large group in the middle where they'll accept it, but they're a little unsure. They may pick and choose, and some of them may even refuse, but they're not really sure. They've just heard other people talk about it, and they just need to know more. So if we can ask, what are your concerns, then that's going to give us the ability to really focus on what the family's concerns are. And again, these may be multifactorial. They may be medical. There may be someone in the family that actually did have a significant reaction to a vaccine, and so they may have good reason to be hesitant. There may be religious or cultural reasons. There may be political issues, or it may be completely personal. But until we ask, we're never going to know. Until we know the reasons, then it's hard to have that conversations. Do vaccines work? Yeah, the data is tremendous. We eradicated smallpox. It no longer exists except in a few government labs. Polio is now only endemic in Pakistan and Afghanistan. Measles, I love this one. We used to have anywhere between 400 and over 700,000 cases of measles in the US every year. They invented a vaccine, they invented a second dose, and now we're looking at cases less than 100 per year. So yeah, it works. It's been tremendous. Are vaccines safe? Yes, amazingly so. All vaccines are vigorously tested for safety and efficacy. Serious side effects are very rare, 1 to 2 in a million. And we've got a great vaccine adverse event reporting system that actually works. And this is really one of my favorite case studies. Some of you may remember RotaShield. This was a rotavirus vaccine that was approved back in 1998. Rotavirus was the leading causes of vomiting and diarrhea, and hospitalization-free dehydration is still one of the leading causes of death worldwide. But there was a serious adverse side effect with this vaccine, is that it could increase the risk of intussusception. That is that telescoping of the bowels into one another. It was identified in early trials, but was not statistically significant. The normal rate was just 1 in 3,000, and this vaccine would increase that risk by just 1 to 2 in 10,000. So a tiny, tiny increased risk. But the data did show that it increased the risk, and that vaccine was withdrawn from use. How long did it take for our safety systems to identify that this vaccine caused increased risk? 9 months. From licensure to pulling from the market, it only took 9 months before we were able to identify that there was an increased risk to the vaccine and pull it from the market. And so that is very, very reassuring that the systems we have in place actually are very good at making sure that they're safe. Some families worry about overloading the immune system. Can vaccination overload the immune system? Yes. If you administered 10,000 vaccines at once, you could probably deplete B cell capacity. I don't think we're at risk of achieving that number anytime soon. And so we fully feel that the immunization schedule recommended by the ACIP is tested, it's safe. And really, there are no data on alternative schedules. So any family that wants one, they have to understand that they're now making that up their own. So you can listen to the science or you can make it up. But again, I don't try to get too combative with families that want to delay vaccines a little bit. If you want your own schedule, we'll work with you. But again, there's no data and no benefit to spacing them out. Do vaccines cause autism? No, we know there have been large-scale studies that found no link between vaccines and autism. There was theoretical risk that thimerosal could increase risk. We removed that from all pediatric vaccines. There's not been any decrease in the rates of autism, so we know that it was not the preservative. Are vaccines made from aborted fetuses? Kind of. Both varicella, rubella, hep A, and J&J's COVID vaccine are grown in human cell cultures from an aborted fetus from decades ago. There's no human tissue in the vaccines. And even the Pope himself said it is fine to get these vaccines. Is my child at risk of getting that disease? Well, it really depends on the disease. Polio? No, your kid's probably not going to get polio. Are they going to get strep pneumo? Yep. Are they going to get chickenpox? Probably. And it'll be bad. So get vaccinated. Are they going to get cervical cancer? Yeah, they really well might. The risks are high. In unvaccinated, unscreened women, it may be as high as 1 in 45. And again, we know probably 1 in 400 to 500, even with regular screening. And the risk of a severe reaction to the vaccine, maybe 1 in a million. So the risks are far smaller than the benefits for any of these vaccines. I'll skip some COVID-19 stuff other than to say, can you get COVID from the shot? No. Will it make you infertile? No. Will it change your DNA? No. Will it make you magnetic? I doubt it. Does it contain microchips that are going to track you with 5G? I don't think that's a thing. And we know that now 99% of COVID deaths are unvaccinated. So get your COVID vaccine too. So what should you do? Well, we know that paternalism is not going to work. Arguing is not going to work. It's all about building that empathetic, caring relationship and having that relationship of trust with your families, where it's no longer a doctor and a patient, but two people trying to figure out what is best for a child that they both care about. And so it is certainly possible to do. Those emotions and those stories are often going to be more persuasive than facts. And so if you've got stories of people who've been impacted by vaccine preventable diseases, that can tell a story. Who do you know that has had normal pap smear, had to have a culp, or had to have hysterectomy because of cervical issues? What issues did you think about prior to vaccinating your own children? What a powerful story that is, to say that, hey, I've looked at this. I care about this too. And I looked at the data and chose to vaccinate my own teenagers too, because cervical cancer and other HPV cancers can be so devastating. And we know that the vaccine is safe and effective. The Ohio AAP does have lots of resources. Well, we've got our Moby and Ties programs. We've got our Ohio Champions for Vaccines program. Lots of resources that are available. We've got our fast vax facts that you should not try to say too fast, but has lots of questions that are commonly asked about many of the vaccines that we have. And again, lots of COVID-19 resources as well. So in summary, vaccine hesitancy is as old as vaccines. We can all be more curious and less judgmental. We can build that personal, respectful, and empathetic bond in the room with families, and that relationship built in that exam room can be very, very powerful. So some references. If you have any questions about HPV vaccine, feel free to shoot me an email, or you can ask them now. So thanks so much for your attention, and I look forward to working with you all on this project.
Thank you, Dr. Karras. That was a great presentation. It was entertaining as well as informative. So that's always a plus. So we appreciate it. I'm going to share my screen, but if anybody has any specific questions for Dr. Karras, and I know some of you were kind of taking notes and jotting some of these stats down, but we will be sharing these slides as well. We're going to put it on our the password protected site along with the recording of this. So if you have anyone in your practice who was unable to attend today, they can still listen to the recording as well as see the slides. So don't worry about that, but I'll share my screen. If anybody has any questions, feel free to go off mute or use the chat. All right, so we will go. Let's see if I can get this to work. Okay, so we have a couple of polling questions just to have a little bit of a discussion with you all. So let's see, I don't do these very often, so we will see. Let's see if I can launch it. Oh no, that's not what I wanted to do. Hold on a second. Oh, it says it ended. What the heck? I'll relaunch it. Okay. Did you see all of them? Do you guys see any of the questions?
I can see question 1 and 2, and actually if I scroll down, I can see 3.
Oh, I don't know why they popped in. I must have entered them incorrectly to get them all at once. But if you guys want to answer these, then we can kind of launch the poll and have the discussion. Sorry about that. But the first one is, how much does vaccine hesitancy play a role in your patient's decision to not get vaccinated against HPV? So if you want to answer that, like how much does that play a role? We have a starring role, a supporting role, doesn't really play a role, or if you're unsure. And while you're answering that, do those who decline the HPV vaccine also decline other vaccines? So if you notice that in your practice, is it really specific to HPV or is it all vaccines? I know some patients will do all the required, but not always all of the recommended. And then what has worked in your practice to change the minds of those who are hesitant to vaccinate against HPV? Provide a recommendation saying it's a cancer prevention vaccine. If you're sandwiching the HPV vaccine, so today you are due, just as Dr. Karras said, today you're due to receive your meningitis, HPV cancer, and Tdap vaccines. If you're vaccinated at age 9 to kind of avoid the whole sex talk, or if there's others. So I'll give you guys just another minute to answer those. not even a minute. We'll probably go ahead and share these. Looks like all of you have answered. So I'm going to go ahead and end it and share the results. Can you guys see those too? Okay. Okay. So it looks like at least a pretty significant role that vaccine hesitancy does play in your practice. So either almost 100% are at a starring role or supporting role. So that makes sense. We'll just go over these. And if Dr. Crick, you want to jump in and have more of a conversation, please feel free. Do those who decline the HPV vaccine also decline other? So rarely, it seems like the most common answer. So I guess that's good. I don't know if they're not declining all of them. We don't want them to decline HPV, but at least they're getting some vaccines. And what has worked, so provide a recommendation, cancer prevention, that's great. The sandwiching and other. And maybe if for those couple of people who answered other, if we want to maybe say what else has worked that you've selected other. If anyone feels comfortable with that.
Well, some of our hesitancy in our clinic is that we're not their primary, like we're not their PCP, we're a specialty clinic. So I think that our nurse run QI initiative to really take the extra step to call the PCP's office while the patient's at their GYN appointment has really helped, because some families will say, I think we got those vaccines. Yeah, I'm pretty sure we got them. I don't know, maybe let's just not do it today. But if the nurse comes back in the room and says, hey, we called your PCP and you actually haven't, or you're due, you know, blah, blah, blah. I think it does increase the uptake of vaccinations in a subspecialty clinic.
That makes sense.
Yeah, that's a great perspective. I think, you know, putting all of this together, and I don't think it's a surprise to any of us that there's something obviously special about the HPV vaccine that really polarizes people. You know, I think it's pretty clear that we play a big role in this, that not that it's our fault that this has happened, but really it's up to us to reshape this conversation. And number 3, poll question 3 will give you a hint at some of the interventions that can help, and there are others as well. So as I was listening to Dave's fantastic talk and then going through these polling questions, I thought, you know, there's, we don't have the rest of the webinars in this collaborative necessarily fully built, and we must follow this curriculum. So I think this would be a good opportunity if there's something on the top of your mind that you think of, or even later that you think of that you think, I really want to make sure somebody hits this point. This is what I'm really struggling with. Maybe it's you know, more detailed conversation about the various interventions that can help, very specific to HPV. Maybe it's one of the things you see here. Maybe it's something else that you feel like is a barrier for you. If you have things that you want to make sure we hit on, tell us, because we can design a session around those sorts of things.
Mm-hmm. Well, I'm going to stop sharing these. I want to go, sorry, I meant to go through all of these previously, but it went back for some reason. So don't get dizzy looking at all of these. Actually, maybe I'll stop sharing really quick and go back to that. We do have just a couple. Feel free to chat. While I do this, we do have a couple of reminders. I know we only have about 6 minutes left, so I just want to make sure that we hit a couple of these. So let me share this again. Sorry, I'm hopping around so much. All right, so let's share it again. Here we go. So just a couple of reminders. that we have. First, are metrics, which you guys are all familiar with. I've sent emails to all of you. And if you are starting to pull that, we do have some of our data deadlines and things like that coming up to share with you. We know we have the baseline data due, which is your January and February data, on April 7th. If you have any issues pulling that or have any questions, we are lucky enough to have an epidemiologist on our team, Zainab, who is on the call today. And so she's going to be looking at that. So if there are any specific questions, I can forward that on. Did you have a question?
Yeah, I've got a quick question. I'm just thinking through being the champion for this, but also sort of motivating the rest of our providers to really jump on board with this.
Mm-hmm.
The metric where you're looking at the total number of 9 through 18-year-old patients for preventive care visits and all that kind of stuff. Is there a way to change that to 11 through 18? Because I can just tell you in our practice, like going and doing the 9 and 10-year-olds is just not going to be a realistic, that's not going to motivate my group. And so if we have a metric that from the get-go, we know it's not, if we do an awesome job and we still come back and that number is not as good as we'd like, it's just because we're not targeting 9 and 10-year-olds. Is there a way to change that metric to 11? I think that would just psychologically help the motivational factor.
I think that's a completely legitimate ask. So I don't think there's any reason from our standpoint why everybody has to be doing exactly the same thing. We actually went back and forth between 9 to 11. And 9 is an intervention strategy that can be really effective. But I completely agree that if that's just sort of outside your reach at this point, measuring 9 to 18 is going to make it very difficult to see if you're making improvements. And so I think that's completely legitimate. I'm kind of thinking through logistically how we keep track of that, but and I might need Zainab to kind of chime in here if there are considerations, but I think it would be okay for each individual practice to say, I really would like to move this to 9, or I'm already doing it at 9. And so I'd like to look at that age group versus your practice and any others to say, that's not something that's within our reach in the next 6 months. So we'd like to look at our numbers from 11 to 18. I think that's doable.
It would be doable. The only concern that I have is, for example, for AAP, if you wanted to combine all the practices and look at overall the outcome of the whole project in general, then we wouldn't be able to, because you have different age ranges, it would, there would have to be something written on, there were different age ranges selected by each practice and whatnot. And it would be a little bit more difficult to kind of want to combine all of that data into one. If you wanted to create like one chart, or you wanted to look at, like I said, overall, all the practices together, what was the outcome?
Yeah, and that's good to know. My impression is that it's much more important that we help practices be successful individually. And that, while sometimes we do look back at project level data, that's not the primary outcome for this project. So I would prefer if we're able to customize to the needs of the practice. We'll get back to you.
Yeah, I think it should be doable, but we'll talk internally to figure out how we want that to look, but I think it should be fine on your end. And we have our individual practice meetings scheduled, so we can dive into it a little bit more when we do that as well. I know we just have a couple minutes left, so I just want to jump through this really quick. Don't forget about the HPV Immunization QI website. So that's where that pre-work survey, our recorded webinar trainings, the provider confidence survey, we have our PDSA template and additional resources. If you have other people from your practice who still don't have access, please let me know and we'll get them access to that immediately. And like I said, we'll also house the recorded training from today as well as our slides. So if you have anybody else in your practice who needs that information. So we're just going to walk through really quick some upcoming deadlines. Again, I'll give you these slides and we'll talk about these as well at your individual meetings. Today was due for the pre-work survey and viewing those recorded webinars. We have a little bit of flexibility with that, but we were hoping to have your pre-work survey ahead of your meeting so we can kind of walk through that with you guys. The practice kickoff meetings are through the month of April. I believe everyone on here has their schedule. So we're looking forward to that. I know we have a couple coming up just next week. Again, our baseline data poll is due April 7th, as well as that fourth measure, the provider confidence survey, is also due on April 7th. Then if you look at May, we have our second data poll as well as our first PDSA cycle. And then we'll have our practice coaching learning session. So our second one of these will be from 12 to 1 in May. In June, very similar, we'll do our third data poll and our second PDSA cycle. And then our practice coaching call, it'll be smaller. We won't have a big educational kind of section like we did today and what we'll do in May. June will just be real quick. We'll kind of walk through the data with you guys. And then July, pretty similar, but we'll have that extended learning session, practice coaching call, we'll have it expanded. So all these dates should be on your calendar, but we will walk through these and make sure you have these. And again, you'll have copies of these slides. So if you need to write anything down. August, we will do our fifth data poll as well as our kind of final practice coaching call. And then September is really our final data poll. And then we have the attestation for the MOC part 4 will be due. I think it'll be September 1st. We may play with that date a little bit since we're kind of pushing things back just a smidge with our start time. And the sustainability data poll. So we'll ask for one more data poll from you guys in December, just so we can compare for the project and see if we've sustained any of our results. One final thing really quick, we have created a RAC card for your practices to use. We think they're colorful and fun and we like them. And so we are offering this as a free resource for you guys. So when we do have those individual calls coming up the next few weeks, think about how many you'd like. We can order these. I can drop them off for you guys in Columbus, mail them to you outside of the city for sure. So this is what they look like. They're front to back for your patients and for parents and to help answer some of these kind of common questions. So it'll be a free resource for you guys. We'll get these printed and sent off to you as well. But I believe that's all we had. So I know we're right at time right now. So we appreciate you guys so much for being here today. And Dr. Karras, again, your presentation was fabulous. So thank you for that. Dr. Crick, thank you so much for being on hosting. And we appreciate you guys and we'll be back in touch and we'll talk to some of you even next week.
Thanks, everyone. Don't hesitate to reach out if you need anything.